Hey everyone, welcome back to my channel, and if you're new here, I am Mariana and I interview the brightest minds of physical therapy. So if you want to increase your knowledge, start right now by subscribing to this channel, clicking on the bell so you don't miss anything, give us a thumbs up and share with your friends. Today our guest is Dr. Amanda Curry and she's going to talk about survival versus survivorship, returning childhood cancer survivors to their meaningful life. Dr. Curry is a board-certified clinical specialist in oncologic physical therapy and works in a pediatric oncology acute care setting. I hope you enjoyed the show. PT Pro Talk podcast is only possible with the support of the forward-looking and innovative company Systems for PT, the Do Anything, Anytime EMR. Systems for PT develops systems for clinics so you can focus on your patients. Go to systemsforpt.com to schedule a demo today. Hi, Dr. Amanda Curry. How are you today?
Hi, I'm good. How are you?
Good, doing well. Welcome to PT Pro Talk. Today we have a different topic that we haven't talked about on the podcast, so I am excited about that. So just tell us a little bit about yourself, your career, for the ones that don't know you.
Yeah. First of all, thank you for having me on. I, like most things in life, feel like I'm about to stir up a little bit, which can have light and shadow to it. So, but specifically about me, I got my doctorate in physical therapy at the University of Tennessee Health Science Center. And from there, stayed in Memphis, the Memphis area. I was one that originally said I would never work in a hospital. I would never work with children. And I found myself in acute care in an adult setting for 6 years, and then transitioned over to a pediatric hospital in town. So never say never. And still work in the acute care setting 99% of the time. I may follow some of my special people outpatient. And so here I am. I just 2021. Time is just interesting since COVID. 2021 got my specialty certification in the oncology section. And here I am about to chat with you a little bit about what it looks like to treat patients with cancer, either active or in remission, and maybe some of the surprising things that we're finding from our friends, both little and big, that have undergone cancer-directed treatment.
So let's jump right in. So what is the incidence of childhood and pediatric cancer and survivorship?
Yeah. So this was so interesting. Throughout the Oncology Specialty Certification process, you basically just cast this wide net of like, what all do I need to know? And honestly, a lot of this I was not aware of the significance, the prevalence specifically of pediatric cancer. We hear all the time about different adult cancers, breast cancer, pancreatic cancer, that have just gotten different spotlight. But tonight we'll be specifically talking about pediatric cancer. And these most recent figures from, I believe it was cancer.gov, were astonishing. So in 2022, just this year, there'll be approximately 10,000 children from birth to 14 years, and then around 5,500 kids from 15 to 19 that will be diagnosed with some sort of cancer. So we're talking over 15,000 new cases at least. And that's just within the US. So much of our time is spent thinking about like our direct community, our direct state, our country, the United States as a whole. And what I'm finding, not only through these fact websites, but also through the institution that I'm a part of like, obviously cancer is a global, like a worldwide issue. And so these next numbers will probably astonish any and all of you. And that being that 13 0.7 million cases of childhood cancer will be diagnosed from 2020 to 2050. So the next 30 years, most of our lifetimes that we're listening to right now. And the impact of that is that most of those will have some form of diagnosis and treatment. And by some, I mean around 45% of those. So around half will receive some sort of treatment. But if they go undiagnosed, 11.1 million of those will die. So like undiagnosed as in like, that's what they're suspecting, that they will have that many cancer diagnosis cases. But a lot of times, especially in underdeveloped world or underdeveloped countries, like we're not only not getting treatment of cancer, but we also have no knowledge of what is actually going on with these children. And so those were baffling to me. We
That's
usually
crazy.
are
Huge
so focused on the here and now of us in the United States. And so there's a lot of, there are a few initiatives that are global initiatives that are wanting to address this. And I find that so needed. And why are we just now thinking about this? So it's something that is, I'm definitely glad that it's being brought to the forefront. But going back to the US, currently right now, we have more than 500,000 childhood cancer survivors in our population. So 500,000 children, anywhere from 0 to 18 are cancer survivors, and likely they will only get older. And then we will see them out in our general population community. So whether you work in pediatrics or not, you as an outpatient clinician, as an acute care clinician, as a pelvic health clinician, I mean, all of these people, we are going to start seeing these patients, and more of our past medical history is going to include some sort of cancer diagnosis. So we've come a long way. Like in the 70s, at least in the US, the survival rate was like in the 60% survival rate. And up until like the early 2000s, up to 2011, I think it was, we got into the 80s, and the goal is to increase that further, but we still have so far to go. And the majority of this talk will be, now that we are having more survivors, what does survivorship look like? And what is the morbidity? What does that look like for us as clinicians? And what are we seeing in our patients? So it's a lot.
It's crazy. When we start having the conversation and I looked at the numbers you sent me, I was just shocked. I was like, I had no idea it was that many people, kids, children. It's just crazy.
Yeah.
And you're talking about the treatment outside the US. So you said that it's hard to be diagnosed. And then once it's diagnosed, is that much different? Do you feel like the treatment outside the US?
I can only speak for the institution and what we see from varying patients that we take in. There's been certain, not to get too much into detail, but certain populations of patients that we have had from different countries through a variety of initiatives that we've been a part of, where we have been surprised, interested in. There's a variety of ways to phrase it, in that, oh, that was your treatment experience before. Okay, interesting. This is what we're going to do here. And that being said, we understand that institutions are doing only what they know, only what they have resources to. I spoke to I partner with, because I helped our institution start their early mobility program in the ICU. So there would be doctors that would come pre-pandemic, and we're just now starting back now. There would be doctors that would come through a program, and they would want to talk about, like, what does it look like for early mobility in your institution, and how can we utilize that within our means and in our situation, our setting. And it was quite baffling to me sometimes what these institutions had access to and what they didn't. There was one gentleman I remember saying that he had like 2 rehab therapists, and I think that included like a PT and an OT within their whole hospital. They were like a 300-bed hospital. There was another individual that I talked to that, in regards to the way that we treat patients with osteosarcoma in the form of a limb sparing, they don't have like the parts, the metal components that we do. And so they have to physically take the kid's bone out. So the child has nothing there and is immobile for that time, irradiate the bone, and then put it back in. So like very archaic type things that we have moved from since like 60s, 70s, 80s, 90s. And we understand, again, like in underdeveloped countries, the training is not there, the tools are not there. And so there are hospitals throughout the country that are partnering with these countries outside of our own to help better equip these doctors, nurses, medical professionals, so that we can bring about what we've learned and what we've utilized to other populations, to hopefully end these devastating numbers of children either not being diagnosed or not being appropriately treated or successfully treated.
That's so sad. So sad.
Yeah.
And what are possible treatment options for pediatric cancer?
Oh my gosh, the list goes, there's far and wide. We could do 4 podcasts on this. It really just depends on the specific diagnosis. Obviously there are leukemias, lymphomas, solid tumors, brain tumors, soft tissue tumor. I mean, all of the things. And each specific diagnosis likely has some sort of protocol, whether that includes chemo and radiation, chemo radiation surgery, whole brain radiation versus just like single point section radiation, proton beam radiation versus another radiation. I mean, it is so variable. And there are lots of institutions that have protocols, and then they have non-protocol treatment plans as well for these patients that have very rare or very intricate needs within their diagnosis and how that diagnosis has responded to treatment that they've given it so far. So the intention of this podcast is not necessarily to say like, this is the specific, because you could go to any website and find out different protocols based on hospitals. What really is my interest is that like we have all of these treatment availabilities. We have all of these brilliant doctors and scientists out there creating these niche offerings for certain patients. And then what is happening after? We get a patient in remission, or we've, technically cured that patient. We've managed their symptoms, and what does it look like 6 months down the road for them? A year, 5 years, 20 years. Our institution had, I think, our first 60-year survivor recently. So like, what does that look like? And the more that we're finding, again, through the research that I had done through the specialty certification that I was a part of, the more you were like, oh, wow. Like, there's a lot that, who's talking about this? Are we talking about this? Is this our scope? Is this like transitionary programs when they're going off therapy? Is it their lane? Is it the doctors? Is it just up to the parents and the patients? So I really want to just bring light to the fact that because we as APTA have adopted this wanting to be treated as doctoral professionals, does this now include this responsibility of us having maybe some tough conversations of, like this may be our new normal, or we may need to be more diligent about looking at X, Y, and Z a couple years down the road, or it's really important for you to advocate for your child in the school setting because of this, so it's so multifactorial. And yet it's still good to bring it to light so that we can have these conversations and increase the overall survivorship of these kids instead of just focusing on their survival. It's not just about they're still here. but like, what is the quality of their being here? So yeah.
And I think that's so relevant for all of us physical therapists, because we are going to come across these patients at some point, and we need to educate ourselves in order to educate the family and help this population, because I don't feel like something that we really talk about. So I think that's the goal of today. So, and what are some possible cancer-related and treatment-related impairments?
So this again could be divided up in so many ways. So you have obviously like acute impairments, chronic impairments, acute on chronic, long-term, secondary. And again, those answers are just as wide as the treatment plans themselves. A lot of you, whether you're in pediatrics or not, could probably imagine some of the impairments from a surgery on a left lower extremity, or certain impairments from chemotherapy. And so what I found was really helpful when I looked at these long-term effects is just the generalizability, I just made up that word, of the effect on these kids. So there was a text that read that 95% of childhood survivors had some sort of health-related issue by the time they were 45. So it doesn't necessarily matter about the specifics of it, though we'll get into it, but generalized, like everyone is having some sort of impairment. And those can get parsed down even more specifically into some like really big, pretty typical buckets. So like 10% of patients that have had cancer will have a secondary cancer 30 years after their initial diagnosis. So if we're going from like the 70s and 80s in the 60% range to now like the 80% range, and we're developing this 10% number based off of like who has yet survived, I can only imagine that that percentage may go up as the years go. And so what does that look like for like screening prevention, especially for like this is really, the first person population I thought of is like outpatient clinicians. Like how many generalized outpatient clinicians see all of these random things where they're like, this doesn't make any sense. You're saying you have low back pain, but like you don't have this, you don't have that, but you have all these red flags. Like I think that as clinicians, like our intuition and our critical thinking skills are going to be so much more utilized in the next coming years, because we're going to have these patients that like, for whatever reason, didn't share on their past medical history that they had Wilms tumor when they were 3 years old. And now they're 45 and they're like, I got this back pain again. Like, what is this? You know? Or like another big bucket that I found that had a lot of significance in late or long-term health effects is breast cancer. Like people that have had childhood cancer are 6 times more likely to have breast cancer. And that's without radiation. So females that have had, this is specific to females, so females that have had some sort of childhood cancer diagnosis, it didn't even specify a diagnosis, are 6 times more likely to develop breast cancer. And those that have had radiation basically are similar rates to if you have the BRCA1 and 2 mutation. So like 70, 80%, whatever that percentage is. And those are just like so general that you like just can't unsee that. You can't unhear that. It's not like, oh, I'm only looking for brain tumor patients. You know what I mean? These are patients that could have had, again, like a Wilms tumor patient where they're 3 or 4 years old. They may not even remember their cancer journey. And they had surgery. They had a little bit of chemo. They needed no radiation. And they were just like lived their normal life. You know, went through school, went through college, got married, had kids. And now they're like, I have this weird thing again, you know? And so it's going to really be up to us as frontline clinicians, especially with direct access, to like have your antennas up and really leaning into like, this just doesn't make sense. I feel like I need to refer out.
Yeah.
So
And
yeah.
Even to educate the parents, like when the kid is there, because these numbers are like crazy high. So like the chances are very high. They have to be aware and look for it. So kind of like pay attention, screen through the symptoms as well as the clinicians.
Yeah. And this is also something that, at least in one specific situation, and I imagine that there are more, is that as much as I love our healthcare system at times, like there are some frontline physicians that aren't even aware of the potential side effects of childhood cancer. I just did a lecture for a school up in the Northeast on early mobility, and the professor's son had Hodgkin's when he was a teenager, late teenager. And he all of a sudden, like within 5 years, developed AFib, and none of his doctors could link the two. And so he went to all these cardiologists, and finally they found out, like, oh, this is a late effect of the treatment you received. And even then it took, she said, I think like 6 to 9 months to figure out, like, oh, wait, it's almost like a diagnosis of exclusion. Like there's nothing, we can't see anything like structurally wrong. There's a little bit of your, some labs that are off, but like, we don't really know what's going on. And so that's something that, with getting radiation therapy and the use of anthracyclines during certain treatment plans, that's another staggering rate, that you were 15 times more likely to develop congestive heart failure, and 7 times more likely to have premature death due to cardiac reasons if you've had chest radiation or the use of anthracyclines during your cancer-directed treatment. I will say that there are ranges of your radiation treatment and ranges of anthracyclines that tip you over the edge and make you more likely. And I love that the institution that I'm a part of is actively doing research to say, like, what is the minimal threshold of treatment that we can give these kids while still having optimal outcomes, so that we can limit these late-term effects, because we know that they're there. And what research can we do and develop on drugs that are cardioprotective? So like, I say all this like doom and gloom, but like there are steps that are being made to help to decrease this. And in the interim, what can we do to still be aware? Yeah, it's staggering, to say the least.
Yeah, that's 15 times more likely. That's like a huge number, 7 times more likely.
Mm-hmm.
And I know that you also told me before about the lung issues, not talking about lungs, so just about the cardiology part. So
yeah. There are definitely chemotherapies that will impact long-term lung issues, and it's something that we see even in our patients that we do follow-ups on from 1 to 5 years. We're already seeing sometimes a limitation in their lung capacity through their pulmonary function tests. And that doesn't have anything to do, well, not anything. It has little to do with if they have a sedentary lifestyle. It's not just that. It's not just like, go out and play some more, go out and like be more active. It's partly that, but a lot of it is, what was your treatment related regimen? What did that look like for you?
Yeah. And what does the long-term late effects look like for pediatric cancer survivors?
So we touched on a couple of them, more on a larger generalized scale. And there, obviously, we have all sorts of systems, neuromuscular, different topics of like pain, fatigue, like all of these outcomes we can put into different sections, right? And so there's still, this is another thing that we found, is that there's a lot of literature out there on adults. There's not as much on pediatrics. So some of the things that we're gleaning are, yeah, they're likely similar to adults, but we haven't actually studied pediatric as extensively, pediatric late-term effects as extensively as we have for adults. Now, a couple of the articles that were really, really well done and really specific to different diagnoses that I wanted to touch on was one that dealt with, I believe it was, one was brain tumor patients and one was ALL, I believe. Yep. And that's what I kind of wanted to touch on because these were so specific to, it's a article out of the program that we have where we follow our patients after their cancer diagnosis and then through treatment, remission, and then post. And so one of the biggest things that we saw with our ALL patients was that the ALL population, their survival rate is like 90% or greater. So like we've done really, really well in the ALL category. And what are we seeing long-term with these kids? Because the study that I'm referring to is when they did the study, these kids were like, I believe like 20 years out from their treatment. So, say that they're in their, 9 to teenage, they're probably looking at like in their mid, late 20s, 30s, right? And so what they found, which was, I like still cannot get over this, is their main deficits were persistent limitations in their ankle range of motion. They had decreased knee extension strength deficits. And when compared to norms, these 30-year-olds were reflecting norms of older adults in their 6th decade of life. So because of the chemotherapy that they were getting, they now have range of motion deficits and strength deficits, which ultimately cause balance deficits, power deficits with their efficiency in walking. And now you have people that are essentially mobility-wise a 60-year-old. Like, how is that even? Like, you could literally, it's one of those things where, if you've ever had like a slightly confused patient where you think that like they're covering really well, like they've really adapted to their environment, and then you get them to do a specific task and you're like, oh, wow. So like, you're talking to these ALL patients, they may have had kids, they may be, community ambulators, they may have a full-time job, and then you put them on a treadmill for 6 minutes and you're like, oh, wow. Okay. There's something there. So it's so interesting that, having limited range of motion in your ankles and knee extension is it's not a death sentence by any way, but it's definitely limiting you from certain activities of daily life and like safety. And I think of these people driving cars, doing hobbies, picking up, there was just the article that came out from the APTA magazine about fall risk, and during the pandemic, people picking things up from their front porch because they were having more deliveries. We don't think about how this is all interconnected until you see that like a 30-year-old is basically performing at a 60-year-old's level in those two respects.
What I think it's crazier for me that all those things, like I never even thought about it. Like now that we are talking about it, I'm going to start paying more attention to history and like these deficits just because we are talking about it. But like, that's not something that would come to my mind like right away when you have like a survivor patient like that. It's just crazy. I think that's why it's so important to talk about that. Yeah. Then now we can at least start paying attention to it.
Right. Exactly. And again, like these are 30-year-olds. So like treatment has changed from 20 years to today in some respect. So the hope is that though we're seeing this now, that again, that slowly starts to downtrend as we try to, tinker with and taper different medications or add certain protective medications, or people just become more educated to the proactiveness of like rehab in continuity of care as a whole. not just like when you have an impairment, but doing like a prospective type rehab model. But yeah, I mean, the brain tumor survivor article as well, same thing. It reflected muscular strength and fitness for brain tumor survivors in that of 60-year-olds, and they were 20s and 30s, due to chemo, radiation, and their resections. So, and this obviously, like when you're not as fit, when maybe you have limitations in your balance, and so there's this fear with your safety, like obviously they're going to be more sedentary and a little bit less active. And so then you get into the whole obesity with that, and you're adding weight to this. It's just like this ticking time bomb.
Yeah.
So yeah, those were the really, really significant articles that I was like, this is so specific to this regimen for this individual subset of patients that like, there's no denying that, it's, yeah, it was just like, okay, good to know. What do we do now?
Yeah. Well, I have so many questions. Do you want to talk about different areas that I know, like you have different areas about the long-term effects?
Yeah.
Or
So
do you feel like you touch now? Feel free.
There's a couple other big ones that at least I personally feel like I'm seeing more of, both in like the acute and chronic, but also that we're finding long-term is, you think of like frailty and fragility in something that is of, again, these like 60-year-olds and plus. And we are seeing more of our kids they're frail. It's not that they are weak. It's not that they're just tired. It's that like their bone demineralization due to their chemotherapies and steroids is like undeniable. I mean, kids that we're mobilizing, and this is more acutely, but like that we're mobilizing and having fractures from trying to stand. Kids that go home and are on maybe their consolidation phase of their chemo, like their leukemia treatment, and they go to like step weird in a hole. Or I had one kid, he was diving for a Christmas present with his brother and fractured his foot, like a normal, like tussling of these kids that like, we just don't really realize like, yeah, like you're not in the hospital and you're not having to stay on a certain campus for a certain cancer directed treatment, but like you still are within that more acute phase of your journey and then post journey. And like, these are things to be aware of like, and how devastating that can be for them mobility wise, especially if they're trying to return to school or return to work. It's that one more thing where it's like, okay, great. This is, okay, we're going to handle this now. And then the other big thing that I personally see, just because I'm so intertwined with the early mobility program at our institution, is what we're seeing with ICU acquired weakness, critical illness polyneuropathy, critical illness myopathy, and just like the PIC syndrome as a whole, like post ICU syndrome. This is just now coming out as an actual diagnosis in the last like 5 to 10 years. And the morbidity and mortality for those that have long stay ICU admissions is also staggering. These patients have cognitive deficits, strength deficits. They have long-term neuropathies. They have a decreased overall quality of life. Their fatigue is astonishingly reported, even over and above what the cancer-related fatigue is that we see from most cancer patients. And then not only that, but like their families are having obviously PTSD from these experiences. And so that is also a large, as our treatment options and regimens continue to evolve, our kids are surviving, but they're surviving a lot of traumatic experiences physically, and outside of that realm, emotionally, psychologically. And this is something that we're going to have to, as acute care therapists and outpatient therapists, understand that like the ICU is not just a like stair step in your journey. It could be like a direct left or a direct right into a certain different journey that you hadn't already planned. And some of our bone marrow transplantation patients, like they're ripe for ICU admissions, like just because of the critical nature and the intensity of their conditioning regimen. So it's just really, really good to know and to really dig deep into like, oh, you had cancer? What kind of cancer did you have? Did you ever have an ICU stay because of that? Like, how long was that ICU stay? Like, just those little bitty questions, adding that extra bit of information can be really, really helpful in developing like your treatment plan and your overall expectations of these patients. So, again, I could go into like cognitive stuff, pain, fatigue. We could be here all night. And for anybody that's interested, literally all you have to do is go into PubMed and just, especially with pain and fatigue, I don't think any of us have any sort of question as to that there are inherent issues post-treatment with those for sure. Because we see that in adult patients and it's very, very applicable to our pediatric patients. So the last thing that I'll touch on is just cognition, and that a third of our survivors will have some sort of cognitive impairments. That's likely due to chemo brain. And then obviously the cognitive deficits that go along with brain tumor survivors that have had like an actual resection, or any of our patients in any population that are getting radiation, either whole brain or the like. So I just really, and I think that the majority of the allied health multidisciplinary team are really committed to this, and that we know that a child's work is their school and their play. And so their educational achievement is one of the top priorities of most families and their care providers. So IEPs, different other accommodations, whether they be physical, 504 plans, those are things that are only going to continue to have conversations more about. And we don't yet have a lot of information about this, or very, very clear information, but what does this look like long-term for like higher education or employment? Because that obviously can have the potential to put a burden on society in general, especially as we mentioned the staggering numbers from 2020 to 2050. So yeah, those were the biggest things that I just wanted to touch on. And hopefully if there's anything specific that your listeners want more information on, we can steer them in that direction.
Yeah. I think it's just crazy how the cancer can impact and affect all these different areas of their lives that we sometimes just don't think about. We're, as you mentioned before, you're just thinking about their survival, but not how their life is going to look like after that. Mm-hmm. And now bring it to the PT side. So what would be the PT role in acute and chronic cancer-related impairments and later effects of cancer? So like, what can we do?
Yeah. So, and again, like globally, I'm about to speak on this. Specifically, we all know like how to treat a certain impairment, addressing symptoms that patients bring to us. But like the bright side of this is that I believe that our population as PTs, our profession, are almost just like ripe for like, we love to educate, we love to empower, we love to resource people. So that is just going to continue. It's almost like something that we know that we're good at, we're going to be able to step into even more. And so whether you are a pediatric therapist right now, or you are an adult therapist that works with oncology patients, or you may come in contact with someone that has had a previous diagnosis, like educate yourself and then educate them. And a lot of it is like advocacy and empowerment of the patient. Just because you had a cancer diagnosis, because a lot of patients feel as though like during their cancer journey, like I was like so much, like they had to take care of me, and they they allowed me to keep living. Like they saved my life. And so now it's like, there's this thought among some cancer survivors that like, I don't want to burden the healthcare system anymore. If I'm not being asked, I'm not going to bring it up. And so empowering your patients to advocate for themselves and also take that time to advocate for them. I know that that Mr. Johnson is saying that like, he's not that confused, but I just wanted to advocate him and say that like, we're having trouble even figuring out like consistent times that he's available during the week to come to my treatment sessions, or like, we're always saying 1 p.m. on Wednesday and he's getting Thursday at 2 p.m. in his mind. And so, just really having the client, the patient's permission to be able for you to be their advocate when maybe they don't know how to, or they're afraid to. Another part to this is working, whether you're in acute care or outpatient, is just leaning on your multidisciplinary team. And just because your multidisciplinary team doesn't live within the same house, like an acute care setting, almost for outpatients, like creating your multidisciplinary team. Like if this person doesn't have a primary care physician, like, do you have someone that that you trust, that will be able to be open and listen to your thoughts on a certain patient? Is there a pain service in town that you really feel like that they do a really good job of providing like whole person care? Contacting like a physiatrist or a physical medicine and rehab doctor in your area. Maybe it's, contracting them out and utilizing those resources. But the other thing that is helpful that I did not know this until I started studying for my specialty certification, was there are the majority of hospitals that are accredited to a certain level to complete cancer care, that part of their accreditation process is that they do a completion of care plan for a patient when they're done with their treatment. So they sit down, there's a person there at their institution that sits down with each of these patients and says, this is everything that you ever had done. This is all of the treatment that you ever received. So they receive that either in electronic or paper copy, and they're able to keep that. So that may be something in the future that people can ask for. Like, did you ever get access to like this completion of care? Like, do you have your care plans? Like, what institution did you receive care from? Can I request that documentation so that you then cannot go necessarily by their word of like, I think I had this chemo back in the day, and you have like the physical information there. Again, also advocating whatever specialty you're in or specific specialization that you may find yourself in, like rehab is needed, we all know, throughout the continuum of care. And so really advocating for, just because you may be seeing this patient for back pain or shoulder pain and that they were just diagnosed with breast cancer, like how are you going to advocate to their insurance companies that they actually need to continue rehab, but not necessarily for their shoulder now, but for general conditioning? So there's so many ways that we as rehab professionals can add to what the future looks like for our patients that have had cancer-directed therapy or are currently undergoing cancer-related treatments. So it's something that it's a gift that I feel like we can give to our patients, but we first have to equip ourselves through expanding our knowledge about treatment toxicities, and through all of the different available resources there are for patients that have or are undergoing cancer treatment.
Yeah. And I'm just curious, I was thinking about when you said about the ankle range of motion, the knee strengthening, the extension. Do you feel like they respond as like a normal patient, or their progress?
Likely not.
Slow?
Yeah. Likely that they are not going to respond the way that your typical general population patient would, because of those factors, because of the treatment that they've received previous to, and because their fitness and their sedentary lifestyle don't allow them to maybe have the endurance or the capacity to go out and do the work that other people without these comorbidities may have.
Mm-hmm.
Yeah.
I think it's just good for us to create some expectations as well, because we have patients that respond certain ways, and then they are not cancer patients, for example, are not responding as quick and as well. And then we start getting frustrated, like, what I'm doing wrong? Like, what should I do? So it's just...
Yeah. And shifting expectations, and also your treatment plan to where like, oh, I can't help you, but also like, maybe we're focusing then on like compensatory strategies. Maybe we know that like this may be your new baseline. So then how are we going to teach you ways to keep you safe within your current capacity? Yeah. Because we don't want to abandon these patients. This isn't like, I can't do anything for you, sorry. But, we're also very ingenious people. Like we like to solve problems. And so I really also feel like physical therapists, we just lend ourselves to be a helping hand to these patients, because we're like, ooh, how could I like modify the way that they sit in their chair so that like now they feel the back of their legs or on the chair before they sit, or like, what could we put in their chair so that they could more easily like touch the armrests first, you know what I mean? Without like actually sitting and touching the chair. It's those kind of things that I think mostly led us to be professionals in this way, is we just like to be problem solvers by nature.
And I think also educate the patients about their expectations so they don't get frustrated as well. So you just upfront, that's what's going to look like. That's what usually happens. So they just don't give up on therapy as well.
Yeah, absolutely.
Any good news about survivorship and pediatric cancer care?
Yeah, I mean, I think a lot of the things that I've already touched on is that it is coming to the forefront of our research and medical partners. There are things being done to tailor, alter, draw back the amount of different modalities that they're using, whether that be certain chemos or radiation, surgical interventions, all of that. And I think the way that we can come together in that is that, we may not be part of a research protocol assessing these things, but our regular population, that knowledge that we have that can equip these patients that are already having these deficits, likely will bridge the gap to where hopefully we're making a difference for them now while these improvements are made. I never want to cast this dark shadow of that we're saving children's lives, because it's happening. And I also want these children to have great quality of life, like as much as possible. I think everyone wants to maximize that, because what is survivorship if we're only focusing on survival? So yeah, I mean, I think also that there are lots of times that people would agree that physical therapists sometimes are these patients' closest medical providers that they're closest to. They know all about them. And so sometimes we may be the only ones that are able to really have the tough conversations with these parents, or with these people as young adults, and say, look, like, this is what it is. Or I really think that like, you need to go get this looked at. I really think that we're just not responding the way that we should be. Let's go talk to our primary care physician. And that may be all that they need to be screened and diagnosed earlier to really make an impact on their life. Not just like, I'm going to keep you safe at home, but I'm going to extend your life for a prolonged period of time because we had these tough conversations, because we as PTs are able to make those connections with our patients. So we have a huge opportunity. I'm just interested to see like how much we step in as professionals to this opportunity.
Yeah, absolutely. And for the ones, I know you mentioned PubMed, but do you recommend any resource of information if people want to learn more about that, or anything that you like in general?
I mean, I do love me some PubMed, but any of the oncology section resources that they have through APTA are great. I just obviously have access to the things that our institution is doing currently. And they do a really good job of keeping us up to date on where they're at with their specific projects. That's where I get most of my information from. But yeah, I mean, I think that through CSM too, we will start to see more of these educational pieces of like, these are screening tools that you can use. So really, even if you feel like it doesn't directly to apply to your patient population, maybe just every year, or when you do check in to these symposium type educational opportunities, like reach out to one, even if it's a 30-minute talk on like late effects of any sort of cancer, whether it's pediatric or adult. I really think that any of those are going to be really beneficial for any clinician, no matter what setting that you find yourself in.
Mm-hmm. Awesome. And just the final two questions. Any advice to clinicians that are starting their careers?
Oh my gosh. Again, I trust your intuition. You know more than you think that you do. And you also know when like something just doesn't feel right. And my advice always to students is that it's better to ask the question and it be the wrong question or an unneeded question than just not asking it at all. Because even if you're wrong, even if you bring up to somebody in the hospital or their primary care or a neurologist and you refer out and you're wrong, at least you're wrong. And you probably learned something from it. So I really am a huge advocate for going with your gut when it comes to your patients. You will likely never go wrong on that. There will never be any harm done by asking for more help and other eyes on a patient situation. And just always, I had a professor in school that just said, don't be a dinosaur. Like, just don't do the meatloaf method where like I've done it this way because I've always done it. Just keep learning. Like anything that interests you, even if it's not pediatrics, even if it's not oncology care, like whatever it is, just keep learning about whatever it is that is particularly interesting to you at that moment.
And what personal qualities or abilities that you think are important to become a successful physical therapist?
Oh, Lord. Well, I just kind of, the inquisitiveness, I think more than anything has gotten me thus far. And because asking questions, I mean, I feel like that's the foundation of any well-rounded individual, whether you're a PT or a teacher or a mom or a whoever, like just keep asking questions. It has never steered me wrong. I'll tell you that it's never steered me wrong. So I'll leave it at that. That feels like intuitively like my number one right now is keep asking the questions.
Better than not knowing the answers.
Yeah. And it's likely, like they always said, that there's somebody else in the room or someone before you that's thought it and been afraid to ask.
Yeah, that's very true. Amanda, if people want to just learn more about you or work or just contact you, is there a way that they can reach you?
Yeah. So I'll give out my personal email. It's Curry, like my last name, Curry, girl, GIRL 24 @gmail.com. You can also find me on Facebook, Amanda Gentz, GENTZ Curry. It's my maiden name. We were discussing origin of names before the podcast started, so that's another one we can look into. And then I'm also on Instagram, the somatic DPT on IG.
Awesome.
So yeah, reach out, any questions you have. I am more than happy. As I said, love the questions. There are no dumb questions. So send them to me. And I'm more than happy to share some of these articles that I got some of these stats from too. So.
Awesome. Well, I appreciate you taking the time. I know you're a busy professional, busy mom. Life is super busy.
Yeah.
So I appreciate you taking the time to have this conversation and share this knowledge. I've been looking for someone to talk about this topic for a long time, and I'm really happy to bring this topic and start the conversation that I think is super important. So thank you so much.
Yeah, I so appreciate you for having me on, like I said in the beginning, but also for you also taking the time to create this podcast, put out this content. This is the next like generation of how we get education, how we do connection within our field. And so I very much love that you have taken the time to this be your platform and to have these professionals on that are so qualified to share their skill set. So thank you.
Thank you.